open it up to partners who might be interested to share any updates you have. And then our next meeting is currently scheduled for June 23rd. Before we get started and I introduce Dr. Sullivan, I just want to go through a few housekeeping items. For those of you who don't know me, I'm Shayla Summer. I manage the Weighing In program at Children's Mercy. Welcome to the first quarterly meeting of 2022. Sort of an interesting way to have this meeting, but I really appreciate the fact that we can do it no matter what the weather. We are getting ready to go into the presentation. I would ask that everyone mute themselves during the presentation to avoid echoes or background noise. You may want to consider changing your view to the presenter view so you can see the person speaking along with the slides. We are recording this presentation. There may be some portions of this presentation that are not appropriate for all audiences. So we will encourage you to think about that prior to sharing. And there is a closed caption option for anyone on the call today who might want that. So with that, I'm going to introduce Dr. Shayla Sullivan. We are really happy to have her as our presenter today. She completed her undergraduate training at Creighton University in medical school at the University of Kansas, where she also completed a residency in adult psychiatry and a fellowship in child and adolescent psychiatry. Since 2010, she's been on staff at Children's Mercy Kansas City, where she currently serves as an associate professor. In July of 2019, she was the recipient of the Shining Star Award for having the highest patient satisfaction ratings among the medical staff at Children's Mercy. That's a pretty high bar, so congratulations for that. She currently co-leads the Suicide Prevention Research Group at Children's Mercy and is completing research on suicide screening in conjunction with the National Institutes of Mental Health. Her current work focuses on providing education for parents on ways to reduce suicide risk for adolescents, including safe storage. So with that, I'm going to turn it over to Dr. Sullivan and allow her to share her screen for her presentation this morning. So thank you, Dr. Sullivan.
Thank you so much for that kind introduction, Shelley. I have to tell you, my dad, when I got that award, he said, "Shay, it sounds like you're back in 5th grade, the Shining Star Award." He just totally thought that was hilarious. We had some good laughs about it. So anyhow, let me see here. Can you guys see my slides?
We can see your slide.
Okay. Just for some reason, it's not allowing me to show from the beginning here, just that slide. I don't know why it's doing that. Okay, well, I don't know. I've never had that happen before.
Yeah, Dr. Sullivan, if you look, it looks like there's a little dialog box open. If you do from beginning again, click on that, and then see it says just right on your side above the S there, it says safe, and the S of safe, it said slideshow, resume slideshow. Try that.
Okay.
There we go.
But it took us back to later. So let me, there we go. Okay, thank you for the help. I appreciate that. So I am Shayla Sullivan. I'm a child psychiatrist, and I'm really excited to be here with you guys today. If I'm honest, this is one of my most favorite parts of my work. I, of course, love seeing my patients. And I forgot to mention, Shelley, I got my next patient moved back because I had an opening, so we don't have that hard cutoff. I'm more flexible with the Q&A. So
great, thanks.
Yeah, but I'm just so excited to be here with you all today. When Shelley told me about the diverse group of people that joined this meeting, I was just thrilled because this is really an important piece of the work that I'm doing, is trying to do a better job of reaching the community. So thank you for being here today. As much as I miss being in a room and seeing everyone's faces, I'm really thankful, like Shelley said, that we have the technology that we can continue our day, and that many of us didn't have to white knuckle the drive into work. I've done that many a time into the hospital, and I don't miss that part. I like being able to feel safe today. So I'm going to first start with an acknowledgement that I am a newer researcher and I'm on a very steep learning curve. And so I'm going to ask for your grace today as I share some of the work that I've done and some of the mistakes that I've made. And I really want to welcome your feedback and your input about how I can do better. You know, in medical school, you spend 2 months on a surgery rotation. So I did a full month of plastic surgery. And sometimes I wish I would have spent that month doing a class on community engaged research, because I think maybe perhaps that would have been serving me a little better right now. Be that as it may, I love this work and I just really welcome your input about how we can do a better job of reaching more parents and caregivers in our community. So today I'm going to talk briefly about the state of mental health for young people today. We're going to talk about the Fab Five and how it can be really helpful and grounding for us in difficult times like a pandemic. We'll talk about why exercise and protected time for sleep are really, really important for young people, how safe storage has saved lives, and the initial outcomes of this program we've developed called Prepped and Ready. And then I want to share with you how Prepped and Ready Experts Edition, our newest video series, is available for the community, and how, if you are interested, you could help us spread the word about it in our community. So if you work with young people, I don't think it's news to you that there has been a mental health crisis for a while. And I'll be honest, when I get interviewed by the media and I get questions like, well, now that the pandemic's here, everyone is struggling. And I want to say, have you been around? Have you seen the rates climbing for the last 10 years pre-pandemic? So we were in a rough spot before the pandemic when it came to the emotional well-being of young people in our country. And things are harder now in many respects. So this paper looks at a lot of different work. And the bottom line is that rates of depression and anxiety for young people have doubled during the pandemic. Things have been worse for girls, particularly later in the pandemic. And we see that from some of the literature with regards to who is coming into the ER with suicide attempts. And I don't have time to go into all of that today, but basically we have a lot of work to be done, even more. And I think this program is really exciting. And so I just wanted to shed light on it. I'm sure most of you have heard about it, but it's something that I use in my regular practice. So these awesome little pamphlet handouts illustrate some really helpful tips to lead healthy, balanced life. And I think this is important because I work with a lot of kids in my office who have struggled with healthy habits. And frankly, many of them have experienced a lot of shame in doctors' offices in the past. I've had kids crying in my office talking about how bad they felt that they went to X appointment and they were told their cholesterol is still too high, and really struggling. And so I think it's important when we want to affect change that we can focus on that in a positive way. And so I use this, I hand this out to families, and I think it applies for everyone.
Hi, Mama. Hey, can I call you right back? I'm on a Zoom. Okay. You okay?
I think we have somebody that maybe needs to mute. We've all been there, right? So the first thing here is an hour of physical activity a day. And then we have 2 hours of screen time. Now, this doesn't mean you need to try to get 2 hours of screen time, right? This is a suggested limit, which I think makes a lot of sense. The 3 servings of milk, dairy, 4 servings of water, and 5 servings of fruits or vegetables. So I'm gonna hone in on these top 2 that I think are particularly valuable. We have a lot of research evidence in the field of psychiatry that these are important. And so I just wanted to shed some light on those. In this study, they looked at lower and middle income countries, and they looked at sedentary time. So time that young people spend sitting. This is not including school. This is not including homework. And what we find is this correlation. We have an increase in depression symptoms for young people who spend more than 3 hours a day in sedentary behavior. So what is sedentary behavior? Often screen time. It can be other things as well. But if you notice the orange line here, we see that it tends to be a bigger impact for females. And so that, of course, is negative. Now, that's just a correlation. But I think this other study is one that I've liked for a long time. This is a meta-analysis looking at the effect of exercise on young people who are diagnosed with depression. So, people come to me and say, well, is medicine the only option? Well, of course, it's not the only option. We need to look at all of the tools that can be helpful for young people that are struggling. And so this is a study that looked at 11 trials. And what they found was that exercise showed significant overall improvement in depression symptoms. So that's great. Now, I want to point out they did group-based activity, light to moderate intensity. There's some other literature that says more vigorous exercise is more helpful. But I think this is an important piece. And the authors say, group-based, could it be that the social connection that's happening during the exercise is also an important piece of the puzzle here? But this wasn't high commitment, 3 sessions per week, 6 to 12 weeks. And so the authors concluded that this could be helpful for moderate or severe depression symptoms. And I would say yes. However, I have a little caveat. I work in our eating disorder center. And at times I've worked with young people who have depression that's extremely impairing, like they're having trouble getting out of bed. They're having trouble taking a shower, basic life skills, because their depression is so impairing. And the parent perhaps has found that running marathons is really helpful for them. And they find running is a great source of coping. And they want their child to enroll in a 10K. And I say, well, wait a minute, Johnny's having trouble getting out of bed. Running a 10K is not an appropriate goal right now. So just want to acknowledge that I don't think it's a one size fits all approach. I think everybody's at a different place. And that's where I think Johnny may need, intense therapy, medication, other things. But I think this is one of the tools we have that can be really helpful. Okay, now, hopefully this is not your child, right? In the middle of the night, up on a screen. And I told you I was going to talk about the importance of limiting screen time. In my work right now, the intersectionality of screens and sleep is my biggest nemesis, I would have to say. It is a huge challenge, and we are finding so many people struggling with this. I get a lot of parents telling me that the teacher is complaining that Johnny's falling asleep in school, and what can we do about it? And often my answer is, well, what does Johnny sleep like? So I think that's something we need to really hone in on, and it's a real get back to the basics kind of thing. So thankfully, the American Academy of Sleep Medicine came out with a health advisory during the pandemic, and they really emphasized the importance of healthy sleep for children and teenagers. And it's really straightforward. There is nothing on here, I think, that is going to surprise you. But again, I think it's a good reminder of things we already know. And sometimes when life gets turned upside down and your schedule is very erratic, it can be very helpful to go back to those basics that we know can guide us and what creates structure. So these were their suggestions. School-age children need 9 to 12 hours a night. Teenagers need 8 to 10 hours per night. And what they say is, you should get that. That is like hard stop. That alone, I think, could improve the quality of life for so many young people. I mean, I am dancing in my office when a teenager comes in and I find out that they were actually getting 8 hours sleep a night. So many of our young people today are on their screens until middle of the night, and then surprised that it's so hard to get up the next day. That there is literature that shows that for the average kid, they got more sleep during the pandemic because they stayed up later, but they were able to sleep later when they weren't going in physically to school. But of course, that's all changing now. So they recommend having a routine schedule. Now, when I go to conferences and I say, okay, I know you want my patient to wake up at the same time every day. That's always the recommendation. Get up at the same time every day. I say, treat American teenagers, and they're not going to get up at 7 o'clock on Sunday. So what do I do about that? The recommendation is usually to not sleep more than 2 hours past your regular wake up time on the weekends. Because when you start sleeping till noon, and then you call me Sunday night and say you need a medicine to help you fall asleep at night, it's because you're throwing your cycle off. So we want to really protect that sleep time. And that's where the screens come in, is that I cannot tell you how many kids are getting access in the middle of the night. And so we need the screens to be plugged in the parents' room at night, so the parents know where they are, basically. And so it's not a temptation. I'm not trying to vilify children. You know, my kids, if they have the screen right next to them, I mean, boy, is it tempting. And so trying to make this so it's not a challenge for the child is really important. But we have to be really specific. I had a family once, that we had this conversation and they came back for the follow-up and they had signs that Johnny was still up in the middle of the night, sleeping during the day. And then we found out that the television was still in the room. And so I have to get really clear and I say all screens, and then I say phones, iPads, laptops, desktops. I list all the screens that I can think of to really emphasize, because for many people, a television feels different than a computer game. And then, of course, we want to have some regular scheduled time for activities, exercise. We want them to get that exposure to light in the morning. And we also, of course, want to limit that exposure to the screens at night, because the blue light from the screen decreases our brain's production of melatonin. That's that hormone that helps us get good quality sleep. And then meal times, of course, right? They reference it's important to have regular meal times. And what I have found in a lot of the families I care for is that when the schedule got off, everything kind of fell apart, because if Johnny's sleeping in, he misses breakfast, then he eats later, and then he's not hungry when the parents are eating. And so everyone's kind of grazing, and that, of course, is not healthy for us. And we know that there's good literature telling us that eating together as a family is valuable for lots of reasons. So I think that these recommendations are real basic, but going back to them is really important because things have been so crazy. Okay, so the headlines are bad. If you notice, these are all from Kansas and Missouri, and there's only one with a positive message in the upper right-hand corner. And of course, we have to celebrate when there's been any good news when it comes to mental health in young people. So Johnson County did a reduction in suicides. So that was reported on. But by and large, we have a lot of work to be done when it comes to addressing the emotional well-being of young people in our community. And this is a listing of all of the different states looking at the percentage increase in suicide deaths for young people, comparing 07 to 09 to 2016 to 2018. And what we see is that across the country, there's been this huge increase. And yet in Kansas and Missouri, we are worse off. We have had bigger increases. And so what this just tells me is that we need to be motivated. We have a lot of work to be done. And you might say, well, wait, suicide is a really complex, awful outcome, and it's multifactorial. There's not just one thing that leads to suicide. And so I want to really agree with that and acknowledge that I think there are a lot of different approaches that are going to need to be taken to address this problem. So I'm not here today to oversimplify it and pretend that if we just make one change, it's going to make all the difference. I don't believe that. But I also think there are some obvious, relatively inexpensive changes we could make that could make a big difference while we work on some of the others, like making sure that there's parity for mental health care, making sure that there's more access, all the disparities that we see. And there's so many changes that need to happen. So when you look at the literature, as I started doing many years ago when I was tasked with helping implement our universal suicide screening program at the hospital, what I found was that safe storage of the actual things that are used in suicides, like firearms, medications, that is one of the most evidence-based ways to prevent deaths. Not medicine. There's only a handful of medicines, very few, that have actually been proven to prevent suicides or shown to, but safe storage has been shown to. And so I really started thinking about, why don't we use this more? Now, I want to give a couple of examples because I think when you're addressing a big problem, you need to search for inspiration, right? And so when we think about Sri Lanka, this is a highly agrarian society, lots of farming, they rely on pesticides. Sri Lanka also had one of the highest rates of suicides in the world. So suicide happens all over the world in different ways. And the government noticed this and said, okay, we're going to make some changes here. We are going to outlaw the most dangerous pesticides. Pesticides, by the way, are extremely lethal very quickly. And so surviving a pesticide overdose is not typical at all. And they said, we're going to outlaw some of the most dangerous, and then we are going to require safe storage so that you can't just have a bottle of pesticide sitting there. You have to have it locked up. What happened? The World Health Organization has reported on this, that the suicide rate in Sri Lanka fell by 50% with these changes, 50. Now, does that mean that nobody in Sri Lanka struggles anymore? Well, of course not. The conditions that lead to suicidal thoughts are still present, depression, anxiety, but when someone in Sri Lanka is struggling, they have a higher chance of making it to a point of recovery when they are in that window of despair. And so to me, this was really exciting. Now you might say, well, did they substitute something else? Some did, and they have reported that there was a subsequent increase in some overdoses of medications that are less lethal than pesticides. And so still, the suicide rate came down substantially. Here is an example that may be a little closer to home, because firearms account for approximately half of the suicide deaths in our community for young people. So in Israel, there is compulsory service in the army. And so we have lots of young people, a high-risk age group, 18 to 24, and they had a high rate of suicides. And so the government made 3 changes. The first was psychoeducation. They said, we're going to make sure these soldiers know what are the warning signs. When do you speak up for help for yourself or one of your fellow soldiers? The second was the embedded mental health care providers within the ranks of the soldiers, so you got to know them. So it didn't feel so strange to be referred to a psychologist because you already knew one. And the third change that many people think made the biggest difference was the soldiers were no longer allowed to take their firearms home on the weekends. And the suicide rate fell by 40% on the weekends. So not having quick access to that lethal weapon at a time of crisis made a big difference. And that really had inspired me to partner with the Lock It for Love program. And so this is from the Grandparents Against Gun Violence. They give out free quality cable gun locks to anyone that will use one. And I started talking with families about locking up medications and just leaving a small amount unlocked so that young people don't have access to handfuls of medicine. I also want to pause and acknowledge that safe storage is not going to be an approach that addresses all suicide deaths. And I want to acknowledge that this is a really hard topic to even broach. I do it because I think if we don't talk about it, we're never going to make progress. And I know that there are people today on this call that probably are really struggling to think about some of this. And so I encourage people to take care of themselves. If you need to ignore me for a little bit or step away, talk to a friend, talk to your boss, please do that. Because invariably, because suicide is so prevalent in our society, most of us have lost someone to suicide or known someone that has struggled with these thoughts or cared for a patient that has, and it's difficult to talk about. The final thing here I wanted to reference is that the open door policy is something that I have kind of instituted with a lot of families I work with, because death by asphyxiation or hanging is the most common way that young women in our society end their lives. And it is hard to proof your home from all the things that can be used in that type of death. So certainly if I have a parent say, hey, Susie wants to walk the dog by herself in the woods behind our home with a dog leash, and I say, no, not by herself, not if Susie's told me she's had thoughts of hanging herself. We're not going to allow that. But this isn't very difficult. And we know with Kate Spade and Anthony Bourdain and many other celebrities, when it's reported on how they died, it makes it harder because there is that contagion effect that can happen. So I recommend open door policy. So when Susie Q has an inappropriate picture on her phone and you confiscate her phone, what happens? Well, she goes up to her room. What's she do? She slams the door, right? And I say, nope, got to keep that door open. And Susie can yell and scream and throw things in her room, and she can use foul language perhaps, but we want the door open so that you can stick your head in and check on Susie. And when she doesn't come down for dinner, we check on Susie, right? That doesn't mean you have to have a long discussion, but we want to lay eyes on her because we know that those long extended periods alone for young people in crisis and distress are the high risk periods. But we also know that many of these crises are short-lived, and that's what makes safe storage so important. So in this study, they interviewed people who survived suicide attempts, and they asked them, how much time passed between the time you made the decision and the time that you acted? And here in this study, the folks said about 10 minutes. About half of them said 10 minutes. So I made the decision and I acted pretty quickly. This is very different, right, than what we see on the Netflix shows that emphasize that people plan their suicides and make cassette tapes about them for weeks or months on end. That's not typical. Now, certainly we see a lot of kids with intermittent thoughts. That's why suicide screening can be helpful to pick up those kids. But when they actually make the decision, it's often very impulsive. And I can tell you, I've interviewed hundreds of kids at Children's Mercy who have survived an attempt. When I say, when did you decide to do this? Often they don't understand the question. They look at me kind of confused and they say, like, when did I pick up the bottle? Or when did I? And it's often they got emotionally upset and they did it right then. And so not having access in that window of desperation is critically important. And we know that especially for young people, this impulsivity can play a really critical role. So this is something we could focus on, is limiting access. The other thing we know is that greater than 80% of suicides that occur with a firearm among young people occur with a gun they found at home. So I have spoken at conferences with a father whose daughter was treated at the sports medicine center at Children's Mercy, and she died by suicide with the firearm that was leaning against the wall of her bedroom. And they used to go to the range together. He would say, you know, she was good with guns. She was safe with guns. She knew how to use them. And he never, in his wildest dreams, imagined that she would turn that gun on herself, and feels like he should have had it secured. So she should have gone through him to have access to it. And so I think about this not only as protecting our patients, our young people, but protecting the firearm owners who are having trouble imagining that this could happen. I'm a firm believer that there is some kind of mechanism in our brains that makes it hard to envision that this could happen to someone that you love. I think it's so exquisitely painful. The other thing we know is that these suicide rates have gone up for young people significantly in recent years with firearms. And this statistic just makes me so motivated to talk to groups of people who are not necessarily mental health care providers, because only 18% of the young people in this Fowler study, when they died by suicide with a gun, were getting mental health treatment. So if you flip that around, 88% are not getting treatment by someone like me when they die. So if we just keep waiting for everyone to get into a mental health care provider, we are going to miss an opportunity big time. The other piece here is that approximately 60% of the suicides were completed with a handgun, which means 40% were with a long gun. And I don't claim to be a firearm expert, but what I've learned from a lot of families is they will say, oh, doc, don't worry. We just have guns for hunting. We just have rifles. We just have shotguns. And there is a belief among some people that those long guns cannot be used in self-inflicted gunshot wounds. And that is wrong. And I know that from my own clinical experience, and especially from talking to lots of police officers now who have come upon horrific scenes with long guns. So we really need to be consistent with our recommendations about all firearms. This study is out of Minnesota, and I think this one is also really important. They looked back at 813 young people who had presented with their first suicide attempt. And it happened that 3.5% had died by suicide during the follow-up period. 71% of them died on their first attempt before turning 25. So I think about all the young girls that we see in our ER who have an overdose. None of them are in this 71%. The males compose less than a third of the cohort, but the majority of the suicides were males, 79% of them. The vast majority of those first attempts were completed with a firearm. And among the attempters, only 41% had a history of a psychiatric diagnosis. So for me, this just is really hard to wrap my brain around, that the first time many of these young people are presenting to the healthcare system as having a mental health problem, they have died. That is the first time we are learning about it. And that to me is so problematic. And so of course we need to do a better job of identifying people at risk. In the meantime, while we're working on getting enough resources for that, safe storage could make a huge difference. Now, when you talk about limiting access to the methods used in suicides, you need to focus on those methods that are highly lethal, easy to use, and very prevalent in a community. Okay, so this is really why I focus so much on firearms, because firearms are very prevalent in our community, and for many people, easy to use and easy to access. And 9 out of 10 times when a firearm is used in a suicide attempt, this leads to death. So this is why I told Shelley, you know, my presentation is not geared towards children. I never want to be the one to educate children about how lethal firearms are. I'm impressed sometimes at how many young people don't seem to see the lethality of things. You notice here that drug ingestions have a much lower rate of death. Now, certainly they still lead to death at times, and they also lead to really bad outcomes. So I helped care for a young person who ingested too much Benadryl or diphenhydramine, which is an allergy medicine. Many people use it to help with insomnia, but this young person had a big bottle on the bedside table and took way too much and ended up having a seizure that was prolonged and then had a anoxic brain injury. So survived. This person did not have a death, and yet did not have meaningful speech and could not walk independently after this ingestion. And so this is why I focus a lot on safe storage of firearms and of medications, and all medications. That's an over-the-counter medicine. So this is a busy slide. Don't get overwhelmed. I'm going to walk you through it because I think it's a really important one. Each little circle here represents a different state in our country. So in the upper right-hand corner, you see a cluster of states: Alaska, South Dakota, Montana, Wyoming. What do these states have in common? Well, if you look on the x-axis, more than 60% of homes in those states have firearms in them. And then you also notice, if you look on the y-axis, they have the highest rates of suicides for young people. Suicides are always reported out per 100,000. So, and you look down here, you see, oh, this cluster kind of on the East Coast, it looks like Massachusetts, Rhode Island, New Jersey, New York. They tend to have much lower rates of firearm ownership, and they also share lower rates of actual deaths. So you might look at this and say, well, gosh, is she trying to insinuate that if you have more guns, you're more likely to be suicidal? No, there's other research we don't have time to get into today that shows that's not the case. What this tells us is that if you're suicidal and you are in that window of desperation, if you have access to a gun, if there is a gun in your home, you are more likely to die. So remember that last slide. If you use the gun 9 out of 10 times, the person is going to end up dying. And so this really argues for either not having guns or being really safe with how we store them. And I grew up the daughter of a hunter. You know, in my other presentations, I have a picture of my dad in camouflage with a dead turkey and a gun, because I want to emphasize to people, I don't think taking guns away is going to be well received or work, but we could become exquisitely safe with how we store them. So here is Kansas and Missouri, and this is the goal down here. I used to call it my fantasy, but I've changed my language because I think it's something that we could really work towards. Now you notice there's still about 45% of homes would have firearms in this goal, but they would be stored so exquisitely safely that young people in our community, unintended users, would not be having access to firearms. And people will look at this and say, gosh, what are they doing in the Midwest? They have a lot of guns, but they don't seem to end their lives as much. So this is what I need your help with. But here's a big but. Do families know that we should be storing firearms safely? Do we talk about this enough? In this study, almost 4,000 parents were contacted, and they asked them, how do you store your firearms? And they compared families without kids with risk factors, so their children didn't have mental health risk factors, to families where the kids had either depression, ADHD, or some other mental health concern. And what they found was those children who had risk factors were no more likely to live in a home where the firearms were stored safely. So somehow we are not getting that message out. And I want to really emphasize that brain development is a big piece of this picture. I've had a lot of parents in my office that say, listen, doc, my son is so bright. He is gifted. He would never do that. And I think sometimes what we're forgetting is smart with intelligence doesn't equate with emotional development. And the amygdala of our brains, that emotion center of the brain, is on fire in the teenage years. I mean, there is so much up and down. I can tell you from my clinical experience, I can tell you from the 13-year-old that I live with, there is a lot of up and down, right? And yet the emotion centers of our brain And if you're a neuropsychologist, please forgive me because I'm grossly oversimplifying here. But these parts of our brain that help us to make decisions, to help us to stop and think, should I roll my eyes at my mom right now? Should I make this smart comment or should I bite my tongue? Those are not fully online. And those are the same parts of the brain that help to think through what happens if you start vaping, if you pick up that gun, consequences. And so helping parents to understand this, I think, is really important, that we may be able to drive at 16 or vote at 18 or drink at 21, but that doesn't necessarily mean that our brains are fully developed and always in a good place to do some of those things. And particularly when it comes to having access to things like large volumes of medications and firearms. So I'm a firm believer that addressing firearm storage and adolescent brain development is low-hanging fruit and something that we could be doing more of to reduce deaths in our community. I will tell you that I started doing this work about 11 years ago at Children's Mercy, meeting parents often on the worst day of their lives. So I was on call a lot more often back then. There were only 4 psychiatrists. And so 1 week of the month I was on call. And I would come to meet a parent after a suicide attempt had brought their son or daughter to the hospital. And in those conversations, I would try to provide education. You know, it's okay to ask your daughter if she's had suicidal thoughts. Many parents worry they will be planting seeds of suicide if they talk about it. And we talked a lot about safe storage. And I had more than one parent ask me a really good question in those conversations. They wanted to know why. Why hasn't anyone ever told me this before? And one dad was kind of angry. And he said, you know, this is crazy. If I would have met you last week, we wouldn't be sitting here in the ICU. And so I thought, you know, often in our work, right, parents inform us. And I think these parents really taught me that we need to do a better job of prevention. And I could spend 2 hours in the ICU interviewing this family in crisis, or maybe I could spend that same 2 hours in a room of 100 parents and talk to them about prevention. You know, pediatricians are the prime example of prevention. I mean, well child checks and immunizations and bicycle helmets and seatbelts. I mean, they've got it down, right? But most children don't see a psychiatrist. And most parents wish their child never has to see someone like me, right? And so often when families refer to us, it's like we're coming in when the house is already on fire, trying to be helpful. And I think doing more prevention and sharing these messages with parents before the crisis is really what is in order. So I developed Prepped and Ready, and we started with live in-person presentations, which was really fun. I didn't realize how fun it was until I was relegated to a Zoom screen. And I partnered with the Grandparents Against Gun Violence, who always bring a law enforcement officer, which was wonderful because I don't want to pretend that I'm a firearm expert. And they showed proper use of a cable gun lock. And they also showed on a dummy gun, all kinds of different ways to secure firearms, biometric safes, all kinds of things. So what we did was we paired information with a toolkit. And the literature here is pretty clear. You can talk to parents all day long and give a lot of great education, but getting people to actually go home and make changes is hard. And if you give them the tools and make it easier, they are more likely to do it. So I was lucky enough to get some initial funding. And so in our toolkit today, what we have is a stackable medication storage box. I was kind of picky. I wanted a bigger size that could get some of those 90-day supplies in there. And this is one I've had at our home for years, and so I know the quality. And then 4 weekly medication organizers. So the goal here is to lessen the amount of medication that is unlocked in the home. I don't think most people are going to get in and out of a locked cabinet multiple times a day, but this makes sure that teenagers do not have access to handfuls of medication. And then not pictured here, we give them a bag with a bottle of dish soap. And the goal there's a video in our series about proper disposal of medications you no longer need. So getting those medicines out of the home. And then firearm owners also get this cable gun lock and a gun lock box. We learned from a lot of the parents that they didn't feel like a cable gun lock was going to be an option that would work for them. A lot of people worry about having an intruder. And so we wanted to give people options. So we give them this education, and then these are the lovely staff who have helped me. This is really a team effort. Lots of folks helping make this happen. So these are the participants from our first 10 live in-person presentations. We just published this in February. And if you just glance at it, you might say, gosh, that looks kind of familiar. That looks like Shayla, doesn't it? We've got a lot of middle-aged white females that live in the suburbs that are educated, right? So this was one of my mistakes. Communications and marketing put together our flyer. They put my picture on it. And I didn't like that, but I didn't have a logo and I wasn't sure what to do. And so we just went with it. So who knows how much impact that might have had. We did try to have some presentations in communities where we would have gotten more diverse representation, but attendance at those was not as good. So we are continuing to work on how do we get a more diversified sample, because we really want to check and see if this intervention works in a variety of communities, not just one community. However, among those who participated, we found that the odds of storing firearms in the safest manner possible, that's locked up, unloaded with the ammunition locked separately, increased 5 times. That we were very excited about because it seemed that this small intervention seemed to make an impact on behaviors. Now, you're probably not surprised to find most people keep their medicine unlocked at home, right? And so after the presentation, 2 weeks later, when they went home with the toolkit, we found that more than half had disposed of old medications that they no longer needed and had locked up medicines in the box. And then more than a third were using those weekly organizers. So we were excited about that. This, though, is the part I'm most excited about. These are quotes from our current video series. And we asked people, how do you feel about this presentation? Do you think it provided value? Across the board, 89% strongly agreed that it provided value. Nobody disagreed. So it was either strongly or somewhat agree. So we were really excited about that because the firearm owners and the non-owners felt in a similar way. I was cautious. I have been really informed that, hey, Shayla, you live in the Midwest. I've actually been told by some people, you know, sweetie, you probably shouldn't talk about guns because that's not going to go well. You know, it's a really politicized topic. And I've just decided, of course, I think we have to. We just have to be cautious about how we do it. And we haven't gotten any hate mail. We haven't had anybody say, you liberal gun hating doctor. So we're very, very excited about that part. So COVID came, of course, and I was a lucky researcher. Many people had to shut down their work. And I thought to myself, well, we could pause. And a lot of communities said, please pause, come back in the fall when this is over, right? Because we didn't know how this was going to go. And I thought, nah, you know, I know I can't do a risk of a super spreader event live in person. Why don't we try technology? Let's try some webinars, because I didn't want to stop. I knew all these kids were at home, not getting the supports of school, and figured we might as well keep going. So here I am on a Zoom screen. If you see where my eyes are going, you know I'm looking at that number at the top of the screen, right? That's the feedback you get on a Zoom screen. How many people are joining or leaving the presentation? But anyhow, we did our webinars, and now we're on our 3rd iteration of Prepped and Ready. One of the things that I have been aware of is the fact that if we want to get a more diverse audience, we have to be flexible and we have to work with where people are at. Many parents that are working multiple jobs who don't have childcare or don't have transportation are not going to make it to that 7 p.m. meeting that the school is hosting. So I wanted to make some videos that they could watch on demand whenever they have time. And so we have these 11 videos now. They're 3 to 5 minutes each. It only takes about 45 minutes to participate. And what happens is they log on. If they want to be part of our research study, they sign this consent form just electronically. You can do it on your phone. And then they do a brief 5-minute survey, and then they watch the videos, and then we email them the post survey all through RedCap, and they put their name and address, and we mail them the toolkit. If they want to just watch the videos, they can. They just won't get a toolkit. So our goal was really to scale. We want to reach more people, and of course, like I said, a more diverse audience. We started out with 1,000 toolkits. In Kansas and Missouri is where we are targeting. And you don't have to be a parent to participate, like a biological parent. If you're a foster parent, if you're a grandmother, but you're raising kids, our goal is to reach people that are raising children at least half the time. If a parent, if a couple is divorced and they live 2 different households, that's fine. Both parents can participate, but we aim to just send 1 toolkit to each household. We do not have Spanish yet or any other languages. That is a goal that is on our list. We first wanted to see how this worked before expanding and getting funding for that. The toolkit value is up to $70 for the firearm toolkit. We have color flyers, and I'm going to show you those, and we can mail those to folks. We also have different options to help people share out this information if they want to. These are the topics that we are covering. And one thing I really want to emphasize is that it's not all about suicide. I feel really strongly that if you do suicide prevention night, you may get some people, and I've been invited to speak at those events, but that's a hard topic to market. And many parents, the research is clear on this, feel that their kids don't have those struggles. So about half of kids in the literature who say they've had suicidal thoughts, their parents are not aware of it. And so I think what I wanted to do was include topics that come up in my office a lot, things that I talk to parents about where we would like to give anticipatory guidance early. Vaping is one of those. I've had a lot of parents ask about vaping. It's not something they grew up with. They know very little about it. So when we started this project, I went and I bought my Juul, learned about all the vaping, reading about it. And then I visited a local high school, and they said, Shayla, we could have given you a whole box of Juuls, so we've confiscated. Anyway, we wanted to provide a mixture of topics here. This is Dr. Alvin Singh, one of our pulmonologists, who of course is an expert on vaping. So I was really excited to be able to include all of these different voices and experts. I never wanted to just have it be me, but it's hard to get this number of people to agree to be available for 10 different nights of the year. So that's why I had to just do the presentation myself early on, but this way we're able to include a lot of different voices. So you see we've got people from different parts of our hospital here. We have a psychologist, we have physicians, we have a police officer, social worker. We also have a video created by one of our nurses in the opioid stewardship program that shows how to properly dispose and store medications. So I'm going to see if this can work. Dr. Amy Beck, who some of you I'm sure are familiar with, graciously agreed to be part of it. We just have a 30-second clip of this that can be shared on social media to help people learn about the opportunity.
It's always important to focus on balance instead of dieting because diets don't work, plain and simple. It's important to address bullying for everybody's shape and size, but particularly for kids who are overweight. They tend to get so many comments about their weight. Because weight loss, if it's recommended, is a good thing, but not if it's happening because it's unhealthy or by an unhealthy.
Oops, I stopped that a little early, but that was her last statement. Okay. So we have the videos because we would like to be able to share them with people, and we also would like them to participate in the research. So we have those clips from each one of the videos that can be shared on social media. Are you guys still able to hear me and see me okay? I just want to make sure.
Yes, you're good.
Yes.
Okay, very good. Thanks. I just heard a sound that sounded like it might have cut off. So different ways to reach caregivers in our region is something that we're looking at here. We have our email, so preptandready@cmh.edu. That's pretty easy to remember. If anybody ever has questions, you can reach out to me through that. What I referenced earlier is we have a partner toolkit that's just been updated. It has suggested language that can be cut and paste into a newsletter, an email, discharge paperwork. If you're seeing a client and you want to share this information with them, so that you don't have to recreate the wheel yourself. It also has our logo, images, pictures, that kind of thing. The other thing that I like to invite people to do is to connect me with community leaders. You yourself are leaders. One of the things I have done is I've spent a lot of time, Sunday evening on my computer, just reaching out emails to different organizations. And what I find is that doesn't really help you very much. It really is much more likely that you're going to have progress if you have a connection with someone, if someone gives you a warm handoff. And so lately I've been really lucky. A lot of people have been willing to introduce me to the pastor at their church or to the leader of their school organization, and we can provide them information. We know that everybody is interacting in different ways. And so some people want more of a digital platform to be able to share with their community. and others want just color paper flyers that we can send to them, but we welcome that. This is just an example of the different flyers that we have. It's all the same information, just different images. And of course, you notice I've got a lot of dads in these pictures because we're hoping to recruit more men to participate. We've been lucky to get a lot of moms, and we just would like to get everybody represented. So these are my children, and they are excited at the idea that you might be able to help us spread the word about Prepped and Ready. So I am going to stop here and see what questions you guys might have, or concerns or feedback, anything like that. I would welcome it.
Thank you, Dr. Sullivan. That was fantastic. Really eye-opening, a little bit emotional, but great information. And I really appreciate you taking the time to share this information with our group, which really is looking at how we work, how we promote healthy lifestyles broadly through community organizations. So I'm going to invite anyone who has any questions for Dr. Sullivan. Feel free to unmute yourself or raise your hand, and we can call on you, and you can unmute yourself and ask her. But before anyone else asks a question, I get to ask mine. And the one I have that I'm hoping might be helpful, in our breakout room, we have people from across the state. So we had somebody from Christian County in Missouri and somebody from, I think maybe it was Cooper County. So we're really happy to be reaching places outside of the Kansas City metro. So my question really is it okay for those groups and organizations in those areas to reach out to you for access to this information and participate in your research?
Yes, yes. So we purposely made this for Kansas and Missouri. And if I'm honest, we've had some people sneak in from North Carolina and Texas and Georgia, but our goal is really Kansas and Missouri. This is where Children's Mercy serves patients. And yes, we do not have clinics in the far reaches of both states, but we want to reach people all over. We know that the rates of suicides for young people in rural communities tend to be higher, and that is thought to be linked to the higher rate of firearm ownership in the community, and also often the lack of resources that are available. So I just had a meeting with Pawnee Mental Health, which is in Manhattan, Kansas, yesterday. And so I am thrilled beyond belief to hear that there are people here from outside the Kansas City metro, because I would really like to get this outside of the metro. We really want it all over.
Great. That's great news. I do know there are a couple of people who put information in the chat about how to get a hold of them. One, it looks like, is with, I think, Johnson County WIC. One is with Parents as Teachers. So I know your admin, Amy, was on the call. If she wants to take a look at that and write down some of that information, that's great.
Sure.
There is one question, a comment and then a question. So Martha says, we're seeing an increase in the incidence of suicide with firearms by women in our maternal mortality review. And I heard a report recently that the rate of female suicide by firearm is increasing nationally. Are you seeing the same increase in adolescent females?
So we have seen an increase in the lethality of the suicide attempts for young women across the board. One of the challenges is that the data always lags a little bit, or at least the data that I have access to. So I can't tell you about data in the past year, but yes, we have seen an increase. Much of the literature I've read attributes it to the increase in death by asphyxiation or hanging for young women, that tends to be more common than firearms, but the firearms are there, and there are incidences of that. The other thing that I didn't have time to include today is the increase in people of color, particularly young African Americans. We have seen a doubling in the rate among the younger set, so those that are 10 to 14. Really concerning. There has been a long-standing kind of message in the mental health world that the Black community doesn't have a problem with suicide. I mean, I've heard reporters say this on the news in the last couple of years, and that's just plain wrong. And I'm hopeful that the messaging is changing so people are aware that this is a problem that we need to do a better job of addressing, because we're not, obviously, we haven't been able to tackle it yet.
One other piece I'd like to emphasize is something you brought up in your presentation, but it's never too early to have this conversation. And I think one of the comments that you shared in your slides was really about, I wish I had this when my kids were young, you know, in preparation. So way
Yes.
ahead of time.
Yes.
So just want to make sure, I want to emphasize that again for anyone who's interested in helping us share this information.
Yes.
Right.
Can I just comment on that? Because I failed to say that we purposely made this available for parents raising kids up to the age of 18. And so I had a mom reach out to me last week and she said, well, I have an infant, so I wouldn't qualify, right? And I said, yep, you qualify. You have a child in your home. And the reason for that is we know that locking up medications and firearms is important for younger kids too, right? I mean, there's clear research that a 3-year-old can often fire a firearm. And so for families that are keeping a gun under the couch cushion, it's really important to encourage them to safely secure firearms. The one caveat is that my videos are geared towards raising kids in the preteen and teenage years. And so if you promote it for someone who just had a baby, they might say, well, I don't really care about learning about the teenage brain right now. And I could respect that. But if you felt like, gosh, I would like to encourage these young families to safely store firearms and medication, we're still happy to have them participate, because we feel like, I personally need to do that research project. I think if we start earlier, it would be easier to adopt, because I think it's easier to imagine your small, innocent child getting into a bottle of medicine or using a firearm inappropriately because they're young and they're naive. That we can imagine. But your 15-year-old wanting to overdose or use that gun on themselves, I think is much harder for parents to envision. So I think if we start these habits early, it can make a big difference.
Yeah. Yeah. Excellent point. We also, I'm looking in the chat now, we also have representation from Nottoway County.
Okay.
So really excited to hear that. So very interested in flyers in that community as well. And Girls on the Run is happy to share the message. So really, really excited to see that. Looks like Robin has his hand up.
Hi, Dr. Sullivan. Great presentation. You know, it's such a heavy topic, but it's just so important. I'm curious, I don't have children in middle school or high school, but is there any type of education or curriculum or screening that's embedded within, say, like the public school system to talk about some of these things or to ask about some of these things? Or is that kind of what you're hoping for in terms of increases in prevention efforts?
Well, I think we need that. I don't think it's consistent across the board. So like my daughter goes to Trail Ridge Middle School, and they recently had someone from Kansas Suicide Prevention Headquarters come and give a presentation. And they were really cautious to notify the parents repeatedly before they came, you know, if you don't want your child to be present, let us know. But I don't think it's consistent. A lot of schools have implemented Signs of Suicide, which is a evidence-based program that's been tested, but it's variable. I mean, we have some legislation that now requires school employees to have 1 hour of education about suicide per year, and that's not a whole lot, but I think it's better than what we had previously, because we know that teachers and those that work with kids on a daily basis are on the front lines. I'm a firm believer that this is like CPR, that, you know, if you had a heart attack or cardiovascular event at a picnic in 1950, you died, right? Unless you had a family member that was a cardiologist, because no one knew CPR back then. Well, now, how many people on this call know CPR? That doesn't mean that you're a cardiologist, but you could do something in the moment to try to save that person's life until you get them to the experts. And that's how I see this, that we all have to be better equipped of how to ask those questions so that we can identify people at risk and link them to supports, and also make sure that their parents are aware that they're doing proper safe storage at home, that kind of thing.
And I guess as a follow-up, given that it seems inconsistent between school districts and schools, maybe it's just because I watch a lot of sports, but I'm aware of a lot of athletes who have taken their lives. And I'm guessing that coaches and, sports league coaches and administrators, they probably have zero to no, zero to little training on some of these things.
That's a great question. I have had coaches reach out to me like on a Saturday and say, hey, a girl on my soccer team, I noticed cuts on her arm. What am I supposed to do? So one of the big messages in Prepped and Ready really is encouraging parents to speak up when you see a concern, to call it out, to say something. And we talk about what's the worst that could happen if you say something versus if you don't say something. I think many of us feel like, well, I don't know what to say, but usually when there's a suicide death, people saw warning signs and maybe they didn't know what to say or how to say it. So I think that that's a really good point. I don't think the coaches have to know everything, but I think knowing some basic questions. The Columbia Suicide Severity Rating Scale has something called the Lighthouse Project, and it's online. It's a free 1-hour training. It's built for non-mental health people. So if you're a police officer, a postal worker, it teaches us that we all have the ability to identify risk and then help that person get resources. And so I agree with you. I think that's really important. I think we all need the education and the training. Frankly, I don't think we do need more psychiatrists, but we also need just more lay people who are aware of warning signs and what to do.
Yeah. Thank you.
Yeah. I have to say hi to Joan Delahunt. We went to school together for many years, and I was excited to see her face today on here.
She just made that comment in the chat that she's known you since preschool.
Yeah.
Well, Dr. Sullivan, I want to be respectful of your time. I know you have a patient, or you're still in clinic today. So I want to ask you if you have time for a couple of other questions, if anyone has them, or if we need to move on. Are you good?
Yeah.
Any other questions then? I'll reach out to the group. I've noticed a few things in the chat. It looks like other counties, the St. Joe, Missouri is represented here. I saw that Turner School District is really interested in getting some of the information and flyers. Anything else that anyone would like to ask Dr. Sullivan while she's here today?
Well, I just want to thank you guys for your time and your attention. And I see some of the information in the chat. I'm so excited to reach out to those folks. One thing I wanted to ask Shelley, I don't know if you send a follow-up email to folks that were on the call, because I could send that partner toolkit to you to share with everyone. I mean, I'm happy to send it out to individuals as well. I just don't want to miss anyone. So that was a thought I had. And someone had asked about the slides. I could put those in a PDF and share that as well.
Great. Yes, that's great. We send a monthly newsletter out. We'll include that. Not the link to the recording, because we want to have that caveat that this isn't meant for everyone. We want that disclaimer. We will have the recording available, but we're going to ask if anybody wants that link to send a request to us directly. Okay. The slides, we'll share the PDF of the slides with everyone, and then we will share any updated information with them following the meeting as well. We'll include it in our monthly newsletter as we have in the past.
Awesome.
Okay, so with that, I'm going to ask you to join me in giving Dr. Sullivan a standing ovation from your own. Thanks again, Dr. Sullivan. This was fantastic. So appreciate your time this morning. Have a great afternoon.
You too.
Okay. And now, to follow up on that, we always think role modeling is very important, and we're happy to have Sammy Mansfield with us today, who's going to lead us in an actual physical activity break. Welcome, Sammy, and I'm going to turn it over to you.
Hey, Shelley, thanks everybody. I love this stand up because that's actually what we're going to do. Shelley and I talked a little bit about sometimes we do these activity breaks and we stretch, and I don't know about you guys. I mean, it feels good, but sometimes getting up and moving feels so much better. So we're going to do a quick a movement scheme called a Tabata. For those of you that don't know what a Tabata is, this is my go-to. It's going to be 20 seconds of a physical movement and 10 seconds of just either a recovery or standing posture, etc. So first thing I want everyone to do is stand up for a moment, stretch your arms overhead. I'm going to go ahead and adjust my computer so you guys can see me. Yes, I am not in Kansas City where there is snow. I have a little bit more sun, so I don't mean to be faking it, but I have a little bit more sunlight for you. But what we're gonna do in our Tabata today, you're gonna need a firm place to sit, stand, or you can just skip your chair. You're just gonna stand and sit, good posture. So you wanna have your shoulders back. As you stand up, I want you to press your arms overhead. I'll back up just a moment. And I really want you to reach to the sky, try to pull those arms by your ears, sit back down, and then stand back up, squeezing your booty. Every time you stand up, squeeze your butt. No one's standing behind you, they can't see you. We're gonna do this for 20 seconds of work, 10 seconds of recovery. So now that you're comfortable with where you are, if you don't have a chair, you can also do it independently with a squat, whatever you wanna do. I'm gonna start my Tabata timer. I will include this in the chat afterwards. If you want to, you can take out the arms, you can go a little bit slower or faster, however you want to do it, all right? All right, here we go. Everybody ready? Down and up, squat, and then press. If this feels really good, pause at the top. As you sit down, make sure your shoulders are back, your posture is good. Every single time, push through those heels, take a couple of deep breaths. After heavy topics, we need to really get some good breath in. All right, last one, guys. All right, stand up if you're up or down if you're down. Check your posture, pull your shoulders back, tighten up your belly, squeeze your butt. Round 2 coming, here we go, and begin. Down and up. If you wanna make this a little bit more of a workout, pick up your tempo, go a little bit faster. If you wanna make this a little bit more of a recovery, slow down and really stretch. Make sure you smile. Good job, everybody. And rest. So now I'm seated, so I'm gonna work on my posture, rolling my shoulders back a couple of times. Downside of Zoom meetings. Ready? And go. And again, if you wanna make a little bit better range of motion, you can take that chair away and just do this with your body weight, however you wanna do it. Weight is in your heels. Good job, everybody. Good. And rest. If you're standing, a couple of other things, you can even try standing on one leg, checking out your balance, working your core a little bit differently. A lot of things you can play with here. Ready? Round 4 and begin. Down and press. Nice work, everybody. We're already halfway through. Good. And rest. A couple of options. If your shoulders are getting tired, just do your legs, or alternatively, you can just do your shoulders, however you want to do it. This is your movement. All right, round 5, here we go. We're officially in the back half. It's amazing how you feel after just 2 minutes of movement. Doesn't really take a lot. Good. Almost there, guys. And rest. Again, check that posture, roll that head side to side, loosen up that neck. You might feel a little bit of cracking or popping. All right, ready? And begin. All right, it's our last 3 rounds. Again, if you want to pick up that tempo, try to move just a little bit quicker, feel that heart rate increase. Make sure you're still squeezing your booty every time you come to the top. Those glutes quit working when we sit a lot, so we want to definitely engage them. And rest. All right, guys, 2 more to go. We have 1 minute. 1 minute. All right, ready? And go. Last 2 rounds, make sure you push yourself just a little bit. Really reach those arms up to the sky. Almost there. Nice job. And rest. 20 seconds left. All right, pulling those shoulders. Ready? And go. Last 10 seconds. Good work, everybody. Almost there. Good. And rest. Nice job. Good job, everybody. All right, hang on, I was gonna come back over here. So I was gonna tell you guys, as all of us as fitness professionals, or I'm sorry, not fitness professionals, as medical professionals, this is one of those things that I think is really great to do in a meeting. You can move, whether you're dressed in nice fancy clothes or wearing heels, it doesn't really matter. You don't have to do a squat or a press. But often, a lot of times in a meeting, this is a really kind of fun way to get people engaged, both mentally and physically. And it's amazing what you can get done in just literally 4 minutes. So I'm going to add a Tabata link in the chat so everybody can see that. I have a free app on my phone that I use for my timer. And it's, again, super fun and something you can do with everybody. Shelley, how do you feel?
Awesome. I think it's so great.
I feel like your heart rate's up a little bit too.
Can you tell? You say go a little faster. Well, I did.
Good. That's awesome.
Thanks so much for joining us, Sammy. This is really great. In fact, Sammy has been a member of the healthcare sector work group for the Kansas City Physical Activity Plan. And we've had multiple conversations about this and are really trying to take a lead on providing opportunities, not just for how to share being more active with other people, but also what to do for ourselves. So a change we're making to our monthly newsletter is a just for you section. Sammy is helping us build that out and including information just like this. So different ways for you to be physically active, whether it's during the workday or something you want to do at home. So I'm really appreciative of Sammy coming today and leading us through that, Tabata. So
absolutely. Can we share, Shelley, after this group? Oh, sorry, that's mine. Can we share the monthly one that we did for February, just so people could see how they could do a Tabata a day for a month? We can share that one out.
Yes. Let me see. Okay, Veronica may be able to put that.
I know where to find it.
And then we can include that again in the monthly newsletter in case people missed it the first time and promote it again.
Yep. Awesome. Thanks, you guys. Good work.
Thanks, Sammy. Okay, with that, I'm going to go back to sharing my screen and we will continue through the weighing in rest of the meeting. So there is our activity break. Thank you all for participating in that. And we're just going to go through the different physical activity plan sector updates. We'll get started with the schools group. I think I saw Robin Stewie on. Robin, if you're still on, do you want to give a little schools update?
I sure will. Can you hear me okay?
Yes.
Okay, great. Thank you, Shelley. And you have our next meeting date up there. And anybody that would like to join us, please reach out. We'll send out a reminder with the link. We would love to have you. I'm also excited. I'm sorry, I didn't announce. I am Robin Stewart. I'm the co-chair of our school sector, and I'm excited to welcome a new co-chair that's going to be working with me, Christine Sharonberg. And Christine is the physical education instructional coach with the Kansas City, Kansas Public Schools. So excited to have her joining us. She's been part of our group, but joining us as the new co-chair with me. Excited about that. Our next schools meeting you see there. One thing we are working on right now, and over the next few months, we have a couple main focus, and one is a task force that will be working on professional development for teachers. We'll have more to come on that in the future as we're breaking out and really working on what professional development in the area of physical activity needs to look like, and the teacher for the teachers in the classroom, and maybe utilizing our physical education teachers, to help make sure we're sharing those messages out as well. And then a second task force is currently working on Bike Month and resources and activities for that month. And I'm going to pass it over to Jill and Carl to share a little more about that and what they're working on for Bike Month.
Morning, everybody. I don't mean to step on Jill's toes here. We have a Bike Month. Oh, this is Carl. Sorry, I'm the Education Programs Manager at Bike Walk KC. And like mentioned, we're leading the Bike Month Task Force this year. Bike Month, for those of you that don't know, occurs in May. as soon as the weather kind of becomes good for that type of thing. So we are meeting with a group of folks from around the metro with different backgrounds professionally to kind of decide what we're going to do as far as how to compile all of our resources to put out to groups, communities, schools, etc. And this is taking place on the 24th of March. I'm trying to find the time, but I believe it's 11:30 a.m. A relatively small group, but we didn't want to get too many people involved, but we're finding representation from different parts around the metro. So stay tuned. After that meeting, we'll have more updates on exactly what we are planning to do and how to execute all of our strategies. Thanks.
Thanks so much, Carl. We're excited to be able to share that information and help promote Bike Month with you all. Okay, early childhood. I think I saw Rhonda on earlier. Rhonda, are you still on to give an early childhood update?
I am. Good morning, everybody. I'm Rhonda Erpelding, and I am the sector lead for the Early Childhood Physical Activity Plan. I'd like to invite any of you to participate in our next meeting, which is going to be March 24th, which is Thursday, from 9 to 10:30. That is our weighing in early childhood group, and we're utilizing that time to be able to bring people together to work on the PA plan. Last month, we have set our implementation groups, and you can see those on the screen. Just to highlight, we're going to be focusing on professional development, policy and practice, tracking our impact and resources. We're excited to see that we've got 2 of our leads for these implementation groups, and we'll be utilizing about 30 to 40 minutes of our March 24th meeting to work in small groups, these implementation groups specifically, and work towards some of our goals. We have aligned our implementation groups with our strategies. So we are excited to really get into the weeds and continue to work on our goals.
Thanks, Rhonda. That's great information. Really excited to see the group is moving into some implementation groups and some action steps related to those. Parks and Rec and infrastructure. Robin, do you want to share an update on that? I think there is a meeting and a meeting date, and I apologize for not getting that into this slide.
Yes, our next meeting is going to be on Wednesday, March 30th from noon until 1 p.m. And the Parks and Recreation and Infrastructure Group at that meeting are going to be discussing the 4 new implementation groups that we're launching. Those are around empowerment, education, and engagement, policy, design, and programming. So if you're interested in Parks and Recreation and Infrastructure, or if you're interested in one of the implementation groups associated with the 4 that I just mentioned, please join us at noon on Wednesday, March 30th. You can go ahead and put your name in the chat box if you're not currently on the email distribution list for the Parks and Recreation and Infrastructure group.
Great. Thanks, Robin. Healthcare. Veronica, do you want to give a brief update on the healthcare sector?
Absolutely. So the healthcare sector has 3 subgroups. The first is the billing group. This group is working pretty hard to find ways to improve the healthcare reimbursement system so that physicians can be reimbursed for physical activity assessment and counseling. The second is curriculum. This group is working on an exercises medicine curriculum to implement in healthcare professional educational settings. Right now, their focus is on medical students, but they hope to branch out to other professional schools. And then our last one is Just Walk. This group is powered by the national program Walk with the Doc. This program brings people from the community to listen to a healthcare provider on a health-related topic while taking a brisk walk. So this year, our first walk is taking place April 9th from 9 to 10 a.m. We are still looking for volunteers. If you're interested, please email justwalk@cmh.edu. And our next healthcare meeting is taking place on April 5th from 12:15 to 1 p.m. So I just talked about Just Walk. I skipped ahead, but yes, so this is taking place in April 9th, our first walk from 9 to 10 a.m. at Pearson Park. It'll take place every second Saturday of the month. So please join us. If you are looking for more information, please scan the QR code on the screen. And if you are looking for flyers, please email justwalk@cmh.edu.
Thanks, Veronica. We're really excited to be able to host our first in-person walk after almost a year delay. Looking forward to that. I'll give the faith-based settings update. So as many of you know, we try to work across sectors to promote programs or activities that help people within the Kansas City area be more physically active. And so we are currently partnering with UMKC and a Walk with a Doc program they have going on over there to implement a walk within a faith-based setting. So we are working with Calvary Community Wellness Center, which is not far from Children's Mercy Hospital. It's just south of the hospital. And it's right across the street from Calvary Baptist Temple to implement a walk. And our goal is to have the first walk there in May. So we're partnering with another group to make that happen. So stay tuned for more information about that. Mass media.
Yes, hi. I'll provide the update here. So mass media sector has completed strategy and tactic development. They spent much of last fall and the early part of 2022 developing and finalizing those. So those are now complete. And so now we're identifying next steps and what the first implementation projects are going to be in the mass media sector. Obviously, when you think about effectively communicating messages around physical activity and healthy lifestyles, the mass media sector is going to play a big role. So we expect lots of big and exciting things out of this group going forward. So if you're interested, if either you have experience in media campaigns and communications, or if you're just interested in how this can be applied to your work and some of the things you do, feel free to join us. Again, it's Tuesday, March 29th, 12:30 to 1:30. And again, put your name in the chat if you're not already on this distribution list.
Thanks, Robin. Just a few general weighing in reminders. We encourage you to like us on our social media channels. You can find updated information on our Fitastic website. And for those of you who are interested in participating in any of the sectors that we mentioned and getting the monthly newsletters for those sectors that will have meeting invitations and information about the next meetings, please use your phone to scan this QR code that will take you to our newsletter sign up. So I'm going to pause for a second and let you all do that if you're interested in doing that. I will also mention we have a couple of other sectors that are working, I'm sorry, let me back up for just a second. One of the sectors I did not mention is business and industry. We do have a lead for that sector, and we are getting started trying to get in feedback from people in businesses, so related to employee wellness, what are priorities related to strategies for that group. If you have any interest in sharing feedback with us, please let us know. You can add that information to the evaluation because we are currently putting that survey together and distributing it within the next month or two. Okay, moving on. So I apologize. I put this slide in here and then I forgot to dump anything in it. I did want to mention some updates about our meeting invites and Zoom links. We've noticed in a variety of our sector meetings, it's been difficult. People have either missed the meeting or they have had a hard time getting the Zoom link. And so I just wanted to take a minute to share how this system sort of works. And we're we're tied by the systems that we use. So if anybody has any great ideas for us related to different systems, let us know. We currently use Evite, the Evite platform, to share meeting invitations, which means you can add it to your own calendar. When you add a meeting invitation to your calendar through Evite, it may or may not show the actual time of the meeting in Central Time. So we want to make sure that everyone double checks the time. We always state what the time for the meeting is going to be, but you need to check your calendar invitation to make sure that the time that is showing up in your calendar is the same time as the actual meeting. You can't adjust that meeting invitation in your own calendar. You can adjust the time so it shows up correctly. The other piece we want to let you know about is where to find the Zoom link. So when you add an Evite meeting to your calendar, the link that shows up in that meeting invitation takes you to the Evite platform and the information about the meeting. We have the Zoom link always in the details about the meeting. So you click on the Evite link, it takes you to Evite. In the Evite platform, you go to the details information and the Zoom link will be found there. So I just wanted to take a few minutes to share that information with you and make it just about as clear as mud for how to get into find the links and get the correct information on your calendars. So we're always happy to help and troubleshoot as needed, but just want to make you aware of some of those challenges that we have. Okay, as a reminder, we're still sharing prepped and ready information. Feel free to reach out to us to get additional information. We will be pulling your names and emails from the chat if you've expressed that you're interested in getting flyers or additional information related to prepped and ready. And again, another thank you to Dr. Sullivan for sharing such great information today. We are still hiring. So if you were at the last quarterly meeting, we mentioned this at that time. Again, we still have an open position with the weighing in program. If you yourself are interested in applying, please let us know or share the information with anyone else you know that you think might be a good candidate for our open full-time position. And last but not least, I'm going to pause here for just a minute and open the floor up to anyone else to share partner updates if you would like to with the entire group. Feel free to just unmute yourself and share any updates. Nothing else at this point? Okay. Well, that's great. Well, we are always happy to help you get the word out about things you have going on in your communities, your organizations, information to promote healthy lifestyle. So with that, I'm going to give you a few extra minutes back in your day. We're ending about 15 minutes early. Please use the QR code here to complete your meeting evaluation. If you're not able to do that right now, we will send out a link to everyone who attended tomorrow, so you can complete that through the survey link if you'd prefer to do that. Right now, our next weighing in quarterly meeting is scheduled for Thursday, June 23rd. Please feel free to hold that time on your calendar. We are crossing our fingers and our toes to, at minimum, have a hybrid event in June, but we'll share more information about that as we get closer. We don't actually have confirmation at Kaufman, where we typically host our weighing in meetings, but that is our hope for June. So with that, thank you all for joining us. This is Princess signing off for the morning. Have a great afternoon and weekend.